And we do have a number of announcements, so I'm going to get started here. I just want to welcome everyone back to the regional rounds hosted by the Regional Geriatric Program of Eastern Ontario. Hope you all enjoyed your restful summers. My name is Matt Sakelli, and I'll be today's host. I'm the manager of the Education, Knowledge Translation, and Research here at the RGPO, and it's great to have you all joining us online and in person today. So as I said, lots of announcements. It's been a busy summer here at the RGPO. I'd like to report that these rounds are now accredited by both the Royal College and the College of Family Physicians in Canada. So with that, there are some housekeeping issues such as the sign-in sheets. So in person, please fill those out so we can get accurate attendance as well. So we can send you completion certificates so you can use these as credits. For those of you online, if you registered with us, we have your contact information, so that's nice and easy. But if you received this link from a colleague or someone and you didn't register, please just send me a note on Teams and with your name and email, and we can record that. Similarly, if you're joining us from a satellite site in a room with multiple people, we'll need the names of everyone who joined as well so everyone can receive credit and get the survey at the end. So please just send me a note with names and emails of everyone joining in those groups. We'll also be sending out surveys at the end of these sessions. Please fill those out so we can continue to improve these rounds moving forward. We've also had some staffing changes at the RGPO. As I said, busy summer. So our director, Tammy Pulfer, is now the director of surgical outpatient here at TOH, and Lisa McDonald has been named the director. Lisa is also the regional director of the Champlain Regional Stroke Network, so she comes with a host of experience from the regional perspective. I want to thank Tammy for all of her help and leadership and support. Wish her all of her best in the new role and welcome Lisa. Before we get into today's session, I would also like to acknowledge that the Ottawa Hospital is located on the traditional and unceded territory of the Algonquin people and respects the traditional knowledge and healing developed over generations. We've had the privilege and responsibility to serve First Nations, Métis, and Inuit of many backgrounds and from many treaty and untreaty lands and territories, and demonstrate the respect and contributions and cultures for Indigenous people. So for today's session, we have Brady Hamilton, who will be speaking about ethical decision-making and medical holds and discharge planning. Brady is the lead clinical organizational ethicist at the Ottawa Hospital and the Champlain Centre for Healthcare Ethics. She helps healthcare teams navigate complex challenges, offering ethical consultations, education, policy review, and capacity building services to hospital, home care providers, community health clinics, long-term care facilities all across the Champlain region. Brady holds a BA in ethics and political philosophy from the University of Ottawa and holds a master's in bioethics and science policy from Duke University. Her research and professional interests focus on surveillance, privacy, requests for non-standards care, and moral distress in both healthcare and online environments. Please join me in welcoming Ms. Hamilton.
All right. Can everyone hear me in this room at least? Awesome. Thank you so much for having me, for the invite. I think we always love the opportunity to collaborate with other regional programs because our ethics program, although hosted here at the Ottawa Hospital, is a regional program. So thank you so much for the lovely introduction. Before I proceed with more of the actual content, I want to just make sure I mention right off the bat that this is very much a group project. So although I'm the one who's presenting to you today, there are a number of members on my team who have really contributed to the co-creation of all of this information. So that's Mike Kekowicz, who's the executive director of ethics and quality here at TOH, Ali Ladak, who is our regional ethicist at the Champlain Centre for Healthcare Ethics, and Dr. Samal Dalakia, who is our medical director for ethics here at the Ottawa Hospital and who happens to be in the room. So if we have questions later, we can also count on him for some guidance. At different points, you may have heard similar information from any one of us, and you might hear other members of the team talking about this in the future. So I just want to make sure that I give them all credit because it's certainly not a solo project. All right. I too want to just take a minute to give you our Champlain Centre for Healthcare Ethics land acknowledgement, which is, that our offices located in Ottawa are on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation and the Mohawk peoples of Akwesasne. We are very grateful to have the opportunity to work in the community on this territory. We respect the traditional knowledge and healing developed over generations. We're committed to learning and sharing knowledge about the experiences and realities of First Nations, Inuit, and Métis families. who continue to experience settler colonialism across Turtle Island, not just in its impacts, but also in its practices. We acknowledge the persistent disparities in healthcare experiences and outcomes between Indigenous and non-Indigenous people in Ontario, and we strive to remember our shared commitment and responsibility to speak up about and call attention to those disparities and to contribute to reducing them. I've also included a photo here that I took at Bon Echo Provincial Park, which is one of the many areas in Ontario that you can learn about some really rich Indigenous history in the area. So if you haven't been there, I would highly encourage you to visit. It's extraordinary. I don't have any disclosures, nothing exciting to report today on that end. The learning objectives, which have already been shared with you all at a high level. I'm hoping today in this presentation we can identify some common myths and misconceptions about medical holds and talk about the framing in Ontario of our legal landscape. So we'll talk a little bit about the Healthcare Consent Act, the Mental Health Act, and our common law duty. We'll go through a few hypothetical scenarios and evaluate some of the ethical components there that are associated with implementing medical holds. And then we will also sort of briefly touch on the role and responsibilities that substitute decision makers have in Ontario, and particularly in circumstances when we are requiring their consent for the treatment of a patient. Okay, so the first thing I want to do is sort of frame this conversation, because there are a ton of people who could tell you about this, but why have an ethicist come talk to you about this? Why have an ethicist in general is kind of a question we get a lot, and ethical inquiry is really something that almost defines our human experience. It asks us to consider what is important, what kind of person do we want to be, what kind of healthcare provider do we want to become, what is a life worth living, what makes a good decision. And in healthcare, ethics is a tool to navigate and to make sense of all those experiences, right? So it requires some space, it requires choices, and it requires responsibility. And it also requires commitment to dialogue and to respecting the communities that we work within and respecting our patients. But that diagram on the side there, we use a lot in our presentations because we want ethics not to be this sort of existential taxing process for you all. We want it to be practical. So we're really trying to consider ultimately what we should do in a healthcare environment, why we should do it, and then how we should do it. And that how a lot of the time is where things break down. And I think that's sort of important for what we're talking about today. So as we move through this process, there are some, disclaimers built in, right? Like you, from whatever perspective you're coming from, might have additional policies and practice standards that you need to abide by to remain in good standing. And also to acknowledge that as ethicists, no one on our team is going to sit here and give you the right answer. And there's a number of reasons for that, one of which being in most scenarios, there's actually probably like 5 or 6 right answers. And so a lot of times we are far less concerned with good and bad, which is the sort of bottom point here, and more concerned with bad and worse, right? No one's calling us because they know the right thing to do or because the best possible scenario is on the table. If it was, I don't think people would reach out to us in general. So this is the other piece I want to just make sure that we're keeping in mind. So there's a lot of misconceptions when it comes to ethics, and I think this is a good way to kind of tease out some of the nuance here, right? So sometimes ethics and the law overlap, but they're not the same thing. So if there is some law, just one second. So if there is a law that we know exists, we have to comply with that law, and that's important. Sometimes there is no law. That can be confusing. Sometimes the law we have can be perceived to be wrong. So, an example of this is in Ontario, we have a legal mandate to prioritize the treatment of OHIP patients. That can get really complicated when we have providers who maybe have a pre-established relationship with certain patients that then they feel they have to sort of cut off. So once that patient is no longer seeking urgent or emergency treatment, then we are sort of asking our physicians at various points to consider counseling that patient to return to their country of origin to seek that treatment. That's very antithetical to the way that we train people and socialize them to the practice of medicine, right? And yet we have some guidance that we have to do that. Sometimes there are no laws, but we have policies in place in our different work environments that tell us what we can and should do or how we should do it, right? So a good example of this is least restraint, last resort policy. We can disagree on whether or not it's ever okay to restrain someone, and yet we have some guidance from TOH or other workplaces on how exactly we should go about doing that if we find ourselves in a situation where we need to do it. So really keeping in mind that ethics in a lot of these contexts is going to be about harm reduction. So just making sure in the back of our minds we have all these sort of different factors at play. Okay. So I think it's helpful to start with a case. We're going to come back to this guy. So we'll just sort of read the case now, and then I want you to just kind of keep him in mind as we go along. You don't have to memorize it. This slide will return. So we have Mr. R. He's a 75-year-old man who was admitted after an unwitnessed fall at home that resulted in a hip fracture. He underwent some surgical repairs and experienced a period of some post-operative delirium, during which he was disoriented and he was agitated. Mr. R was then diagnosed with some degree of dementia and cognitive impairment. We have some information about his MoCA here, 19 out of 30, that has gradually worsened over the last few months. He's been noted by neighbors to wander in his rural community. He can now mobilize independently with a walker, but he's not able to maintain adequate hygiene without assistance. People have reported that his townhome is disorganized, his bedroom and bathroom are on the second floor, and he's not interested in home or community supports to make it a safer space or to mitigate some of those risks. He's now recovering from his surgery, and he has told the staff a number of times that he wants to go home. His care team is counseling him to consider going to a retirement home or some other sort of supervised settings, where he sort of responds that the hospital is just too noisy, he can't get any rest here, he would rather sleep in his own bed. And so despite whatever degree of cognitive impairment he might have, he has sort of stated consistently now that he is mobile, he's just going to leave whenever he feels like it. So this is a situation we see all the time where healthcare facilities have at-risk patients that express a desire to go home. And this can be really complicated, practically speaking, for a number of reasons. And it also, I think, gives us this really immediate feeling of like, oh, this could go bad very quickly, which can lead to a lot of moral distress. Like, what are our obligations to Mr. R? So like I said, we'll circle back to him in a little while. Okay. In terms of the actual sort of meaty content here, the big question is, what is a medical hold? Okay, so a medical hold is any action taken by a healthcare provider to confine or restrain a person in the hospital when there is some immediate action necessary to prevent serious bodily harm to that person or to others. This is recognized in the Healthcare Consent Act as a common law duty to restrain or confine, and we find that in Section 7. So a medical hold should be confined in time to an immediate situation or an emergency. So shortest period of time or only as long as necessary to prevent serious harm to a person or others. And this can show up in a lot of different ways, right? So this can be something like putting a patient on a locked unit. In certain situations, we might consider that like a medical hold. Can be a sitter or a one-on-one being assigned to a patient because we want them to stay in a particular room or area of the hospital. That can be calling a code white or calling security to come help us with a particular patient when they're trying to leave, not necessarily because they're acutely agitated. This can be something like traditional restraints. It can even be refusing to let people leave the building to go smoke because we're worried they might not come back. And that happens all the time. Okay, the big disclaimer here is that the term medical hold is not a legal term. This is completely fabricated. It is something that has sort of transformed over time. I don't think we have a good consensus on where exactly the term medical hold originated from, but essentially what we're referring to is that common law duty, and this is sort of the language that has been inherited, I think, for a lot of different people, is this medical hold concept. Not a legal term, presents a lot of tension between sort of two main things that we want to keep in mind. The first being a patient's fundamental rights and freedoms, right? So including that freedom of movement within the hospital, outside of the hospital, et cetera. At the same time, healthcare providers responsibility, whether that's real or perceived, to ensure the safety of that patient or of others. And this is where things get really tricky. So I also want to preface this by saying, if we have any Severance fans watching this or in the audience, you'll get this reference. We're big Severance fans in ethics. So you might know the line that Adam Scott says, which is that the work is mysterious and important. We know that medical holds are not quote unquote a legal term. They're not a real thing, but they're happening all the time. So what is it then? And this presents this very legitimate challenge for our team. And I think we held off for quite some time, and someone can probably validate this, like from even creating any sort of guidance, because this is a term that doesn't exist. It's not in the law. It's not available to you all as an order in Epic or any other sort of medical health record, which also means that we can't review them in any sort of retrospective chart review, or learn more about them in a really substantive way, which is kind of a catch-22 if you think about it, because we have a bunch of different people who are operating on different interpretations of this phenomenon, and they're documenting things differently. So we also get this question about, well, can I order a medical hold the same way I could order, a restraint in Epic? And that's something I don't really think we've even kind of landed on definitively. We don't really want people to have the ability to order this, but it leads to more problems where we know that people are doing it and doing it in a really varied way. We, from our perspective, are operating on the knowledge of cases that come to us, but we know there's a bunch of cases that we never even hear about where this is happening. So that's sort of a blind spot for us. And we also can't see who's most affected by these, right? So we don't have a sense of what diagnosis perhaps is the most subject to medical holds, what unit applies them disproportionately compared to others, or is it, some sort of patient demographic that really we seem to want to put on medical holds consistently. So there's all these things we also don't know about it. And yet we kept getting brought essentially a lot of concerns with the way that things are currently operating, right? So these are the concerns as we've tried to frame them. The first being concerns about whether or not we're operating with proper legal authority, right? This can then introduce all these other risks, significant risks, in terms of patient rights, and then potential risks for healthcare providers in the form of college complaints, in the form of litigation, consent and capacity board hearings, the list goes on. And I think the liability monster is really what keeps a lot of healthcare providers up at night. So this is concerning for that reason. A lot of this stems from that variance in practice. So we know that there are significant differences in the risks that we're using, the difference in risks that we're attempting to mitigate when we're using a medical hold. So the difference, a good way to think about this is the difference between an acute risk and a chronic risk. We don't really have a way to differentiate between those two things sometimes. And so a lot of them get lumped into, we'll just put this person on a medical hold. And then also circling back to that concern, part of what makes this so mysterious is the documentation, duration, oversight, and review of these holds, as mentioned. Some providers are going to document very explicitly in their chart, this patient is on a medical hold. Others will reference the Healthcare Consent Act and say, I'm keeping this patient based on my interpretation of common law duty. Others won't document this at all, and they will verbalize to us that, the patient's on a medical hold. And so it just brings up all these sort of questions or concerns, which is where we'll go with this. We've tried to sort of sort some of these out, hopefully. On top of all the practical concerns, we have a lot of ethical concerns about medical holds. So the first is, and I've alluded to this already, is this idea of patient autonomy. So when patients demonstrate decisional capacity, and we'll talk more about that later, we have this principle in ethics, their respect for autonomy, and that supersedes any sort of paternalism, whether that's from a physician or anyone else. That effectively means we need to allow patients to make bad decisions, such as leaving the hospital against medical advice. The second thing is that it brushes up on all these concerns about legal authority, plus or minus our duty or ability to mitigate certain risks. So healthcare providers, wherever you might find yourself situated in the spectrum of care, you all have some sort of responsibility, perceived or real, to ensure the safety of your patients and the safety of others. So the safety of, the team we're working within. And that comes into play with our medical ethics principles of beneficence and non-maleficence, this idea that we need to actively promote good outcomes and we need to do no harm, which requires us all to take some reasonable precautions. And the reasonable piece is where it gets really challenging, to prevent harm from coming to our patients. But at times, we might be overreaching, essentially, is what we're learning through all this work. It's also important to remember that quality of life is defined by each individual person, and risks, which we might kind of think about broadly as like an uncertainty in the outcome. We don't know what's going to happen, can be negative or positive. So there's some potential for harm, maybe, versus a potential for opportunity loss. And just because we're reducing one risk, i.e., we've decided we're going to keep a patient somewhere we feel is safe, we might be increasing another risk. So, for example, if we're thinking about Mr. R, addressing that physical risk by sending him to a retirement home might be at the expense of his social and emotional well-being, if to him it means losing some sense of independence and of dignity. And then we have that fourth piece, which is patient rights. And I always like to include responsibilities because I think we hear a lot from patients and families. I have rights, I have rights. They also have responsibilities, right? So they have the right to self-determination, which is protected by the common law. So two things true at once. We have duties under the common law. They have rights, and responsibilities, to treat hospital staff with consideration and with kindness, and to make good use of our hospital resources, right? So there's a whole bunch of things that are sort of tied up in this medical hold issue from our unique ethics lens. I won't go into this in each term in too much detail, but just to give people a sense of some of the terminology that's going to be coming up, that we're thinking about when a patient is asking to leave the hospital. So the first one is competency, and there are other areas in Canada where competency means what we call decisional capacity in Ontario. But in Ontario, competency is a legal term. So it refers to a person's ability to make decisions regarding legal matters, and that is decided by a court of law. We have to presume that that is intact unless we have some reason to believe otherwise. The second thing is their decisional capacity. And this is really important. So this is a patient's ability to understand the nature and consequences of a decision, to communicate that decision. And I don't mean just, sort of articulate back to you what you just said, but in their own words to say what that decision means and why it's important to them. And to understand what are the risks, benefits of that proposed treatment, which is given to them, offered to them. And capacity is always determined by the MRP. There are lots of resources that can help with capacity, and we'll touch on those later on, because a lot of these cases get complicated when we have patients who exhibit fluctuating capacity, which is a whole other, there's lots of side presentations we could do just based on the information here, but at a high level, that's what we're concerned about. And then we also have these different types of patients in Ontario. So the first is an involuntary patient. That's a patient who's been admitted under the Mental Health Act, and we'll talk about that in a bit more detail. We have voluntary patients. Those are patients who are here of their own free will. They're receiving treatment, and they're entitled to leave the hospital against medical advice whenever they choose. And then we have our informal patients. And I think people get really confused about these patients sometimes. But this is a person who has been admitted under the consent of a substitute decision maker's consent to receive treatment. And we need to make decisions about someone's capacity before we move to their substitute decision maker. As I said, capacity is really the important piece here, right? And the onus is on us as the hospital, as healthcare providers, to prove that someone is not capable. So we never come into a situation saying this person is not capable. And this comes from a very seminal Supreme Court case called Starson versus Swayze in 2003. The Supreme Court of Canada reviewed these laws around capacity to consent to treatment, and they decided or noted that the right to make one's own treatment decisions is fundamental, and that can only be displaced where we've established that a person lacks the mental capacity to do so. So their best interests are not a consideration in determining the question of capacity to consent to or to refuse treatment. So if we think back to our case, to Mr. R, we heard a lot of things. We heard cognitive decline, we heard dementia, we heard about his age, we heard about his MoCA score, we heard that he was described as wandering by others, none of which can be equated to capacity. So that's maybe still a question we have about him, and we can talk about that later. But again, we see this a lot, I think, particularly in the geriatric space. People will say this person has a MoCA score of whatever out of whatever. And unfortunately, that doesn't mean a whole lot to me. I'm not a clinician. I'm not an ethicist. I don't know what my MoCA score is. Like, I couldn't tell you. So that is far less important to me than the conversation we had with a particular patient or their substitute decision maker about the reasons that they are consenting to or not consenting to treatment. As we said earlier, capable people have the right to take all kinds of risks, to make decisions that we might think are unwise or unsafe, and ultimately to make mistakes. And I think we like to protect people a lot in the hospital, and also just, of course, because I think that's sort of human nature. When we see people who are vulnerable, we want to wrap them up and take care of them, or at least I hope that's our inclination. But patients do have the right to make mistakes, and they have the right to regret those decisions, right? And to come back and to say, I made the wrong choice. The presence of some mental disorder or mental illness is never going to be equated with a lack of capacity. And that's important to remember when we get to the piece on the Mental Health Act. And the last piece is that capacity is time and decision specific. So we can have patients like Mr. R, who might not be capable of consenting to something super complex like a surgery, and yet he might still retain the ability to make all kinds of other decisions about medication, about discharge planning, about supportive services. And this can be really challenging, like I said, in cases where we have capacity that fluctuates. So we have all these things going on in our head that we know we're supposed to be aware of as healthcare providers or as supportive services, et cetera. But there's also this piece of internal dialogue, and this is where Dr. Delakia is so helpful in bringing his sort of physician lens to this, right? There's all kinds of things that are going through an MRP's mind, whether that's a physician or for whatever space you occupy, you might still be in the position of proposing a care plan or proposing some sort of treatment. And there are lots of concerns around, will discharging this medically ill patient who I know doesn't have a psychiatric illness, but I do know who is at some sort of acute risk of decompensation, that I know has fluctuating capacity. Am I exposing myself to some sort of significant liability complaint for medical negligence at worst, or wrongful death in even scarier scenarios? We might also be thinking, isn't it my ethical or moral duty to safeguard patients from any sort of harm? We might be concerned if we're detaining a patient without a regard to a specific legal statute, because I think, again, as healthcare providers, you're tasked with so many things. Why on earth should we expect you to also be experts in the law? And so we can kind of come back to that tension over whether or not we want to apply a medical hold to keep someone in the hospital that's amplified to these huge variabilities in the types of risk assessments that we're doing, and in applying the term like reducing the level of risk of unnecessary harm to an acceptable minimum. So how do we decide what's unnecessary harm? How do we decide what's an acceptable minimum? And really a good way to think about this, I think, is like, what's the difference between unsafe wandering and going for a walk? That's going to look different on different people, and we should really only be using medical holds when someone is at the highest risk of harm to themselves or to others. And that's, I think, where things historically have not always been consistently applied, and that's the direction we're hoping to move, is associating a medical hold with a pretty significant level of risk. Okay, so we have all this background information about what's going through our heads, et cetera, and we know that, okay, we can't keep someone legally per se thinking that through on a medical hold level. So how can we keep someone in the hospital, confine or restrain them to the hospital? We're very limited by law, and as such, healthcare providers should be very clear about the legal framework or authority that they're relying on when considering whether or not to confine or restrain a person to the hospital. In Ontario, we have some pretty specific and well-defined circumstances where we can do that. So the first option is the Mental Health Act. So patients who are requiring treatment for a mental disorder and they meet the criteria for involuntary admission, we can confine and restrain those patients to the hospital on a psychiatric hold. However, patients on a psychiatric hold still retain the right to refuse treatment, except in certain cases of court-ordered treatment or emergency treatment. So again, just because we have someone who's presenting with a mental illness doesn't mean that they can't consent and decline certain parts of treatment plans, and that can be really tedious, right? That takes a lot of time to tease out each of those pieces and figuring out what are the things we're concerned about and what are things that actually, in the grand scheme of things, are not that important to get caught up in. The other thing to keep in mind here is that risk of harm to self or others due to a non-psychiatric medical problem or a lack of capacity attributed to a non-psychiatric medical problem, those are also not valid criteria for a psychiatric hold. So in the same way that we shouldn't be keeping people who were anticipating to receive psychiatric treatment on a medical hold, we shouldn't be keeping people who are our concern is medical treatment on a psychiatric hold. And we can talk about what that looks like in a little more detail later. So, our second option is the Healthcare Consent Act. So there are two key elements here under the Healthcare Consent Act. The first is that our medical condition is the primary reason for presenting. So there may be an element that foregoing treatment is the risk of harm to self or others. And then the second piece is our capacity assessment. So we need to do that capacity assessment. We need to deem someone incapable for making a respective decision. Again, time and decision specific. And then if that patient is incapable with respect to the treatment for their medical condition, they can be admitted to receive treatment to which their substitute decision maker can consent under the Healthcare Consent Act. So if we have consent from a substitute decision maker, we can essentially keep people to receive treatment as deemed medically necessary. So if there's a situation where the substitute decision maker isn't present, maybe we don't have clarity on who that person is yet, and there is an emergency requiring immediate treatment, and detaining or restraining the patient is necessary to prevent harm to the patient or others, the patient can be detained or restrained under the common law, but we need to contact their substitute decision maker as soon as possible to administer that obtain their consent and administer that treatment. And it's also important in these scenarios because I think sometimes we end up with patients who are admitted under this sort of auspice to stop administering that treatment when it's no longer an emergency if we don't have the substitute decision maker's consent, and then to seek that consent as soon as possible. So ideally, we always need someone sort of representing the patient if the patient can't represent themselves. So what does this look like in practice? This is sort of the ideal decision-making scenario. We would have a patient that presents to the hospital requiring treatment for their medical condition. We would identify the substitute decision maker and look to them to provide consent if that person is incapable for the treatment of the medical condition under the Healthcare Consent Act. They can consent to admitting the incapable patient to the hospital to receive treatment. That incapable patient may indicate they want to leave, but they can continue to be detained per the substitute decision maker's consent. And if necessary, incapable patients can be restrained if required under the Patient Restraints Minimization Act and the common law. So the third option, which is the one we're most concerned about today, is our common law duty to act. So if any patient poses an immediate risk of harm to themselves or to others, a healthcare provider may confine, they do not have to, that's important to keep in mind, they may confine or restrain a person when immediate action is necessary to prevent serious bodily harm to the patient or to others, and this is our medical hold in effect. So we're looking primarily at non-emergency medical conditions, but some sort of continued risk of harm to self or others that require ongoing treatment. This can be a wide range of things. I think we see medical holds or this sort of inclination to apply this logic to primarily, patients with some sort of cognitive impairment or dementia, patients with some sort of acute medical illness who are not acutely ill, but at a high risk of decompensation in that moment, people with traumatic brain injuries, people with Korsakoff syndrome, people who we know have endocarditis and are active IV substance users that want to leave the hospital to use substances, patients with advanced COPD who might be on home oxygen and they want to leave the hospital to smoke. Like, these are all the sort of scenarios that we see this come up with a lot. And this is our decision-making tree for those types of patients. So ideally, this is what that would look like. We would have a patient who presents to the hospital. They have some sort of immediate need for treatment for a medical condition. So maybe that's that COPD or whatever it might be. The provider is going to do their assessment. Maybe that's suggestive of a need to protect the patient or others from harm or to maintain a safe environment at TOH. The patient has not yet been assessed for capacity. Again, we might be operating on very in-the-moment decision-making. We might put this person on a medical hold, during which time we would want to have that capacity assessment as early as possible. If that person is then found incapable, we would sort of return to our previous decision-making tree, which is that we would continue their admission as an informal patient with the consent of their substitute decision maker. So what does this look like in real life? This is a different case. So this is a case of Mrs. G, a 70-year-old patient who does not have any sort of psychiatric history, who has been hospitalized for 20 days in the ICU for rapidly worsening non-alcoholic liver cirrhosis. She's awaiting a liver transplant. On day 21, she tells her nurse, I need to go. I'm late for my meeting downtown, and they've been calling me all day. Indeed, at 70, she owns a home and works as an attorney, but she is profoundly confused. She has no insight regarding her medical condition. Some nurses try to convince her to stay, but she leaves the room and exits the ICU. They call a code white for an agitated patient, and someone stops her at the elevator. And this is where, again, when we're talking about how do we do these things, the sort of logic breaks down a little bit. Security might refuse to restrain or confine the patient without being formed. So the team calls psychiatry to assess for the placement of a psychiatric hold or a Form 1. Psychiatrist determines then that patient does not have a mental illness as defined by the Mental Health Act and therefore does not meet the criteria for an involuntary psychiatric hold. The patient does clearly lack some decision-making capacity and does not understand the risks of leaving the hospital. She's declining care sort of as a result of this medical condition. So even in a case like this where we might have consensus that the patient should be prevented from leaving the unit or from leaving the hospital because that's the ethically, right thing to do. But ultimately, the team doesn't know in this moment whether or not it's lawful to involuntarily hospitalize such a patient, and they're unsure of the best means of accomplishing this, right? So we hear a lot also of this breakdown in we might order a medical hold or we might want to keep the patient, and then we call security and they won't enforce it. And this is something, again, we're still trying to learn about and understanding how we can kind of bridge this best practice guideline that we've created with security's perspective, because it can be quite distressing for them when they're enforcing these as non-clinicians because they recognize the illegitimacy of a medical hold from a legal perspective. And so at a certain point, they are feeling conflicted the same way that we are, but from a sort of different framework between what they've been told is in this person's best interests and what they know they've been told they can and can't do within the purview of their job, essentially, right? Specifically when a patient is asking to leave. So if we were to devise some sort of decision-making tree for a patient like this, we would see that, we have a patient suffering from some sort of delirium or acute confusion as a result of a medical condition. That patient has not been assessed for incapacity. Maybe we don't have time. Patient at the door. That restraint or confinement is necessary to administer immediate treatment to prevent serious bodily harm. So we should potentially put them on a medical hold for the shortest possible period of time to assess their capacity, to talk with their substitute decision maker, et cetera. And this is really the problem with trying to apply the Mental Health Act in medically ill patients, which we do see that come up a lot. When there's a risk of harm to self or others due to a non-psychiatric medical problem or a lack of capacity that's attributed to that non-psychiatric medical problem, those are not valid legal criteria for the Mental Health Act. So at the same time, this mentally incapacitated patient doesn't need psychiatric hospitalization. She's probably not going to benefit from that, and such an action could actually be quite detrimental. So for medically ill patients who require certain types of care or placement in a care facility, the presence of that involuntary psychiatric hold is also often viewed as an exclusion criteria, and that can cause a lot of delays or complications in disposition planning. So we also want to be really careful when we're considering that because it does have effects later on down the line for these patients as well. So what do we do with all this information? Well, we have tried to create sort of a revised approach and set of parameters. It's not a policy that everyone must follow. It's a clinical best practice guidelines. And what we've done is we've included, a definition at the top there defining what is a medical hold, our relevant patient factors, our required criteria, and then what we've done essentially once we move through that sort of idea, what is a medical hold, when is it appropriate, when should a medical hold be reviewed and or removed, sorry. The important thing there is that it's a temporary measure. And so I've underlined the piece that says for a number of hours, not days or weeks, because again, I can't tell you how often we see patients that for weeks things get so easily copy and pasted in Epic or other electronic health records for each day for the last 2.5 weeks, it'll say I'm keeping this patient under my common law duty. Well, that's not great for us to look at when we're reviewing because for weeks on end, I doubt that people are meeting that significant risk threshold. I'm not saying it can't happen, but most of the times there are other things we should be looking to if we want to keep the patient in the hospital. So what we did to make this practical and hopefully useful for people is created some green zones and some red zones. So circumstances where a healthcare provider can likely use a medical hold. In these clinical circumstances, a health provider should also regularly review the risk of harm to the patient and to others, document the reasons and the justification for that medical hold, and document the duration that the patient will be kept on the medical hold. So the shortest possible period of time and the next steps within that period for the medical hold. So for example, if we need to assess the person's capacity, we need to get in touch with the substitute decision maker, et cetera. Our hope is that if people are utilizing this moving forward, they'll do so with an intention to sort of be productive within that time frame and then reassess as needed. So we have a few sort of examples up there, some sort of threat to life or limb. That's our emergency medical condition with an obvious imminent risk to life. Some sort of acute medical decompensation that poses an increased risk of harm to self or others. That would be an acute delirium. So if we think back to our previous case study, that patient probably falls into that area. And then also conditions that pose some sort of increased risk of neglect of self that can be mitigated temporarily by staying in the hospital. So maybe we have a patient that we know is at a chronic risk of decompensation and we're sort of ready to discharge them. But at the same time, it's the middle of winter and there's a blizzard outside. Okay, maybe we can keep someone until that extreme weather event passes, and then we can review again the risk and engage in some discussions about risk mitigation. Some red zones. So these are clinical circumstances where a healthcare provider should defer the use of a medical hold, seek some consultation with other members of their team or allied teams, ask for help, consult ethics. We hear a lot of abstract risks that I think fall into this category, a big one being a patient that we are concerned about discharging is going to leave the hospital and be hit by a bus, and then I'm going to be liable. That's like the big thing that everyone seems to be concerned about is being hit by buses. Trying to understand that we are equally responsible for inappropriately detaining and confining people for those abstract risks that we can't, as a hospital, mitigate. We can't mitigate risks posed by traffic until the end of time or until we feel this patient is going to be safe. Some other things to keep in mind. So maybe we have a patient who's substance use disorder and they have a chronic risk of decompensation, but we know that about them and we know that they have chosen to live at risk. And so these often are not candidates for a medical hold once they're stable enough to leave the hospital. Risks that are not necessarily mitigated by a stay in the hospital. So example, fall risks, someone with dementia. They're as likely to fall in the hospital, if not sometimes more likely to fall here than they are in their homes. Capable patients with chronic risks of decompensation who can understand and appreciate those risks, but might be unwilling to mitigate them. Again, we see this a lot. So treatment adherence issues with someone with diabetes or other sort of repeat decompensations. And then patients who are designated as ALC, but are stable and their condition has maybe plateaued with no acute risk of decompensation. So again, a patient with a dementia diagnosis, we've said this person's incapable for treatment. They're waiting LTC placement and are confined to the hospital with the consent of their substitute decision maker. But if that person so we can use a medical hold if a patient with an ALC designation decompensates acutely, but then really they would be falling into that green category in the first place because they're trying to leave the hospital and we need some sort of active treatment. We are not simply putting them on a medical hold because they have dementia, which again, I think historically has been sort of a catch-all problem solving in a lot of cases. So we're going to circle back to Mr. R. here. And after all this, we know there are some situations when the team feels a patient's not safe to return home to independent living. So we might recommend a supervised or more supportive living environment like a retirement home. The challenge here is retirement homes and group homes are actually not considered treatment facilities, but they are residences. So even if the patient were found incapable, the healthcare team can't force someone into a place of residence. We hear that a patient is often not capable of participating in discharge planning, which again really only applies if we are considering transferring that patient from one facility to another. So, i.e., we have a patient in the hospital that is then going to rehabilitation or to long-term care, complex continuing care, or those types of places. For patients who are not being discharged to a treatment facility, but who are at risk, we need to think a little bit more outside the box. So consider trying to create some sort of collaborative care plan using our harm reduction principles. Work with the patient and their substitute decision maker. I think a lot of times we're most concerned about patients who might live in a rural area, who are not interested in all these community supports, but as much as possible, try to mitigate risk and use those shared decision-making principles and document all of the efforts that were made to mitigate risk for these kinds of patients. So if we were going to work through our options for Mr. R from most restrictive to least restrictive, option one, the most restrictive option, keeping the patient in the hospital under the Mental Health Act. So we know the Mental Health Act forms at this point, I hope, should only be used in patients that could benefit from psychiatric treatment, not as a means to hold an individual if they don't meet that clinical criteria. I'm going to assume our physician in this case does not think Mr. R would benefit from psychiatric assessment, and we should probably move to the next option. So our second option would be to administer treatment authorized by the substitute decision maker. So a patient can be restrained only to address an imminent risk of harm to the patient or to others. So as authorized by a plan of treatment with the patient or their substitute decision maker's consent in the Healthcare Consent Act. This would require using whatever minimal restraints are necessary and in accordance with the hospital's least restraint last resort policies. So while some people on the team might recognize, there is some risk of harm in the event that we discharge Mr. R as he is, we might not believe that Mr. R meets the criteria for urgent treatment or restraint. Okay, so then we need to move to our third option, which is our medical hold or our common law duty. I can maybe see a case here for a brief medical hold to establish capacity with respect to this particular decision, to present further housing options to Mr. R, see if we can work together to come to a decision that makes everyone comfortable, to consult ethics, or even, like I said, to bypass some sort of extreme weather event. Maybe we're in the middle of a heat wave or it's actively snowing very heavily outside for this patient that we feel might be at risk. On the flip side, if your justification for medical hold is that we have a patient who has a chronic risk for wandering, that likely won't work unless we have some other assessments done in terms of capacity, because as described, that fits within our sort of red zone criteria. So if we want to use a medical hold, we would need to establish what's the purpose of that criteria, document from there. We would need to move to our next option, which is that we could discuss some options with Mr. R. We could try and convince him to stay in the facility temporarily while we make some better discharge plans for him. This would require ongoing informed consent to the plan of care. And ultimately, if he's not amenable to that, we would go to option 5, which is to discharge Mr. R with the best possible negotiated plan using a harm reduction approach. When there are ongoing care needs and patient safety considerations, the discharge plan should really include patient and family engagement as much as possible. We want to provide follow-up instructions. We want to make sure patients know that if they leave the hospital and they decompensate, they can always come back. Leave them with medication instructions and prescription instructions, et cetera. So we could explore some things to that end with Mr. R and see if we can set him up with some support services. In the end, he may do better than anticipated. I think that's one of the things we don't always think of, is sometimes these patients are far better at mitigating risk in their own environment than we give them credit for. And keeping this in mind the whole time, that he can decline all of these supports and ultimately it doesn't feel good. That's that feeling of moral distress, but it is okay to know that we've done all the right things and he still might want to leave. So there are two things to really sort of keep in mind here. specifically for, dementia or TBI or those types of concerns that prevent a patient for caring for themselves, like Mr. R, which we feel results in no safe discharge option for the patient. They might meet the criteria for some sort of informal or involuntary status, but that lack of a safe discharge option does not automatically qualify them to be admitted as an informal or involuntary patient. With that, I have one more slide to share, which is sort of our take-home message about this. And it's kind of our, if we think about a three-pronged test, that's hopefully what this is. And that's the idea that outside of an emergency, when we have a patient who does not have any psychiatric overlay for someone who is at risk of harm to self or others, a medical hold for that type of patient should mean they have a medical issue requiring treatment, they are awaiting a capacity assessment, or there's an immediate plan to assess for their capacity. And this should be used for the shortest possible period of time before the patient is either declared voluntary, involuntary, or informal. And so ideally, we need all three of these to be met. We need to be performing ongoing risk assessments and documentation, which is really important. Our hope with this information is not to scare people or to police or punish people who have been using this historically. We're really hoping to kind of change our attitude and culture around risk assessments here, not just at TOH, but throughout the region, and hold each other accountable, ask questions, be curious when people are trying to do these things, and reach out when you need help. Other things you can do, or some action items if you're feeling like very proactive. You can write your MP, you can talk to your city councilor and other elected officials to really bring their attention to the lack of safe discharge options we have for so many patients like Mr. R or other people who we feel are at risk. We know for a fact that this is not the best environment for them to be cared for, and there are all kinds of risks associated with being in the hospital, and yet we just don't have the resources to send them back into the community with confidence. I would also say to rely on the other resources that are available to you. So here at TOH specifically, we have a wonderful neuropsychology team who can help with capacity assessments when you're concerned. We have social work, we have patient relations, and of course, our ethics team is happy to support you when these confusing and complex situations do arise. So we are very, very happy, like I said, to be able to share this with you today. And I'm happy to answer any questions you have either about medical holds or about the ethics services in general in the region.
Any questions? Yes. Pass out some microphones here. We'll pass out some microphones.
Is that working?
Yes.
Okay, great. Thank you for a great talk. I wanted to just make a couple of points. We still at TOH don't have a set process with set forms, with set durations, with set review and set ability to contest. It would be very easy to take the Form 1, Form 3 and just erase the top and put medical hold on top. So that's very dangerous, that set process. The other is a point and a question. It's going to be a little bit of a challenge. So delirium and dementia are defined in the DSM, the Diagnostic Manual for the American Psychiatric Association. Hence, they are mental health conditions. They've been treated as mental health conditions for decades, for 25 years of my practice. And for 25 years, they fell under Form 1 and Form 3. I understand psychiatry wasn't happy. I mean, they got involved in so many cases, they couldn't do their primary job. So I understand that it wasn't tenable, logistically supportable, but still they are under the American Psychiatric Association Diagnostic Manual. They are mental health disorders. Does the Mental Health Act very explicitly exclude them as mental health disorders? Because if it doesn't explicitly exclude delirium and dementia, there's still a very valid argument to make that these are mental health disorders and they fall under the Form 1 and Form 3.
Great question. I would also maybe rely on Samuel for a little bit of the answer there. In terms of like the actual medical hold application, I don't know that it complicates the decision that much more, because if in fact they are valid under the Form 1 or Form 3 criteria, we can utilize those to that end. If they're not, then we would need to be explicit about the medical condition that we're using for a patient and with the medical hold. But Samuel, do you know? Does
Yes, thank you, Dr. Mohan, for this great discussion. I think a few things that are clear is with regards to delirium, because that being the most common contributing factor to delirium being the medical condition. Hence, that becomes a little bit easier to say that this may not fall um, into the Mental Health Act, just because the cause of the delirium is largely medical, and then mitigating the risk is mitigating and addressing the medical condition, which a psychiatrist would not be able to do, even though delirium can be a neuropsychiatric condition. So kind of makes that a little bit more easier as compared to when you're talking about neuropsychiatric disorders or major neurocognitive disorders, which have clearly an overlay. Again, the short answer is no, it does not very clearly state that in the Mental Health Act. However, the risk assessments often fall into the category of which would then be mitigated by medical interventions rather than pure mental health interventions. And so that's where kind of the push to say, okay, we're not there yet. I guess a lot of it is the dichotomy between the body and the mind, which in its origin should not be there. But in a way, that's where, so when we bring in the idea about risk mitigation, and if medical interventions are the tools that will mitigate the risk more than psychiatric interventions, then they automatically kind of fall into the Healthcare Consent Act and less on the Mental Health Act as a operationalization of it. Although the language in the act, which is legal, does not really state that. So if that's kind of behavioral and psychological symptoms. Well, that's well brought out. So clearly that would be the gray area where that would clearly be a collaborative aspect, I guess, between geriatricians and geriatric psychiatrists who can together decide. We often admit them, meaning if they're admitted under psychiatry here in D6, they're still on Form 3, and then they're still admitted there in psychiatry. So that is still being done. So it will be a collaborative decision. It depends on where they are. Effectively speaking, if they are on medical floors, then it would be the Healthcare Consent Act, psychiatric floor. Yeah.
Next question, go ahead. In the pink.
You specifically were talking about healthcare providers, and just to be clear, is that physicians only? Or
So anyone who is proposing a treatment then becomes responsible for assessing capacity with respect to that specific treatment. So a lot of times in the hospital, for example, someone will go in as like an SLP or an OT, and they will need to get consent for the patient to do whatever it is they're doing as part of that particular profession. In cases like these, sometimes that's where things break down, right? So we have an OT who's saying it's absolutely not safe for this person to go home, a physician who's saying, well, I don't have the ability to keep them here for XYZ reasons, which is, I think, part of that sort of breakdown in like, how do we actually do this and get people on the same page when we have, you know, an MRP who's maybe saying one thing, and then we have all these other healthcare professionals that are responsible to their own colleges who are saying other things. So that can be an opportunity to reach out to ethics if that's sort of what you're talking about. Because yes, it's true that each regulated profession has their own structure for assessing a patient's capacity with respect to the treatment they're responsible for providing, if that makes sense.
yes, thank you. Still very complicated.
Yeah, yeah.
Yeah, thank you so much for the talk. Are really relevant scenarios that we see so often in geriatrics. So my question was, a lot of the algorithms that it was nice to see laid out there, they had the capacity assessment, of course. And if we, you know, we can't consult neuropsych for every patient that needs capacity. As physicians, I mean, I personally, in my 5 years of residency, was never trained specifically in capacity. I often use the aid to capacity assessment, or the ACE, which I think is what's recommended by the CMPA. Is this a tool that you guys are recommending for that component, like documenting kind of the ACE, putting it in the chart? Are there other tools that we should be like learning, teaching our learners to use for that point?
Yep.
And when would you recommend deferring to neuropsych in these inpatient like scenarios?
That's a really excellent question. So yes, it's true. So neuropsych is not going to be helpful if you call them up and say, I need help deciding if this person's capable or incapable, point blank, period. They won't do that. They can't do that. Neuropsych is useful if we have a patient who, with respect to a particular decision, we're unsure about their ability to consent to that decision. So maybe that's like an antibiotic, for example. We don't know whether or not their decision to decline this antibiotic is well thought out, et cetera. So they can come and do an assessment for a specific decision. So we want to be really clear when we're reaching out to them. This is the sort of treatment that we've offered to the patient, and this is what we're having trouble with. And it's a really good point too that physicians are not trained in capacity assessments, which is such a huge part of the legal concerns that we see, and the reason that patients essentially end up in the hospital for long periods of time is that sort of capacity, and specifically patients who have fluctuating capacity. It's so challenging. The aid to capacity assessments, I think at this point, if that's the best guide available from the CMPA, absolutely, I would encourage you to utilize that and document really fulsomely. If you ever have the opportunity as well to read a neuropsychology note when they come and do their assessments for capacity, I would encourage you to do so. They're incredibly informative, and you can also get a sense from those types of notes what types of questions they ask, what the responses they receive are, and how they use that information to make their ultimate decision, because they will go through each branch of the sort of capacity test with respect to each decision and say, maybe we've met 2 out of the 4 criteria. And if we do meet 2 out of the 4 criteria, most of the time we need to err on the side of the patient. So that's one thing. The second thing I would say is with respect to certain decisions, like whether or not a patient can decide about if they want to go to long-term care or not, the only people who do that particular capacity assessment is Ontario Health at Home. So that's another really common scenario we see where up to a certain point in a patient's admission, we've never allowed them to make treatment decisions. We think they should go to long-term care. They don't want to go to long-term care. Ontario Health at Home does their assessment. All of a sudden, they've said this person is capable to make that decision. And that can really cause a lot of like friction and butting heads. And then we end up with patients who are here indefinitely because we don't feel comfortable letting them leave. And yet Ontario Health at Home has said they are allowed to decline that admission to long-term care. And it took me a long time to kind of understand, like, those are just 2 completely different frameworks for capacity. And so I can't look at the physician and say you're wrong with respect to treatment, that this person might not be capable, but I also can't look at the Ontario Health at Home assessor and say you're wrong with your assessment, because they're 2 completely different frameworks. So that's another situation where I would say feel free to reach out. Dr. Lisa Walker has done a lot of really wonderful work, as well as Dr. Carlin Kabuka, who works on the transitional care team here and is a family physician. They have created sort of another aid for capacity assessments that I'm sure they're trying to circulate and share. So that can be another useful document that sort of says, these are some questions you can consider asking, and here's how you would document. And it also outlines, if this is the situation you're in, refer to the medical best practice guidelines for medical holds. So that's sort of, these 2 documents are tough because we don't quite know where they should live yet or who should be in charge of them, but ideally they'll work a little bit in tandem. Yeah.
I know there's a couple other questions, and some online. We are over time, so maybe we can pause the conversation and continue at another time. I just want to take this time to thank you.
Thank you.
Ready for your fabulous talk. Remind people to sign in if they haven't done so already, and we will see you back here in a month's time in October for another talk. So thank you all for joining, and we appreciate your time and commitment to this.
Thank you.